Before we start, please like, comment, and subscribe. It helps the channel grow and reach other nursing students who could use this info too.
Okay, let's unpack this. When we think about health, our minds often default to the adult body, right?
Yeah, that's pretty typical.
But the world of pediatric health is something else entirely. It's dynamic, things change in an instant, and the way illness or stress or even just growth shows up is fundamentally different from us grown-ups.
Spot on. A child isn't just a mini adult.
Exactly.
That's the absolute core of it. Their physiology, their emotional landscape, how they present symptoms, it's all unique.
Yeah.
Understanding these distinctions is so key because what might seem, minor in an adult could signal something really significant or even critical in a child.
And that's exactly what we're diving into today. A listener sent in a really valuable stack of sources focused on pediatric health.
Oh, great.
Yeah, covering everything from mental health to genetic conditions and those unique challenges of a child's respiratory system.
Okay, so our mission with this deep dive is to go through these sources with you. We'll pull out the crucial insights, help you understand the key characteristics, the risks involved, and the common approaches to care for some significant health issues that kids face.
Right.
We really want to help you feel well-informed about this stuff without getting bogged down in, unnecessary complexity. We'll explain the details as clearly as we can.
Absolutely. So buckle up. We're going to explore everything from how to spot maybe the less obvious signs of stress in a child to understanding the impact of genetic differences and why a child's tiny airway makes certain respiratory issues particularly urgent.
It sounds like a comprehensive look, all drawn from the material provided.
Definitely.
Okay, let's start with an area that can be, particularly tricky to navigate: pediatric mental health.
Yeah.
The sources kick off by discussing when inpatient psychiatric therapy is considered for children.
And it seems the material highlights one main, really urgent trigger: the immediate risk of the child harming themselves or others.
Right. Safety first.
That immediate safety concern is paramount. And the source notes this can be voluntary by the family or, if needed, involuntary for their protection.
Precisely. That safety net is the absolute first priority. Beyond that acute situation, the sources spend quite a bit of time detailing stress in children.
Yeah, which we all experience. But how does it look different when you're still growing? It's not always obvious, like a DART stress, is it?
No, definitely not. The sources break down the clinical signs into three main buckets: physical, behavioral, and psychosocial.
Okay, can you walk us through those physical first?
Sure. So on the physical side, stress can literally make a child feel sick. You might see complaints of headaches, stomach pain, abdominal pain, general GI upset. It can even show up in things like bedwetting, which is enuresis, or accidental soiling, encopresis.
Oh.
Plus, chronic stress can actually lower their immune function, making them more susceptible to getting sick.
Okay, those physical symptoms are kind of unexpected. What about behaviorally? How does that look?
Behavior can kind of go in two directions. Some children turn inward. They might engage in self-harm, withdraw and isolate, maybe experiment with substance use or overeat.
Right.
Others turn outward, acting out through verbal arguments or even physical fights.
Okay, and the psychosocial side seems more intuitive. Things like anxiety, depression, irritability, anger are listed there.
Exactly. Those are more what we might typically associate with stress.
So if a child is showing these signs, what strategies do the sources suggest for managing it? What can help?
The material lists practical, supportive approaches. Things like encouraging physical activity, exercise, providing outlets like journaling or drawing, teaching calming techniques, deep breathing, maybe meditation or even hypnosis. For some, prayer can be a source of comfort.
Right.
And critically, making sure they have someone supportive to talk to, whether it's a trusted adult or maybe even a peer.
Simple but really essential tools. And how do we know if these strategies, or just, time and support, are actually helping a child get better at handling stress?
Well, the sources suggest measuring improvement by looking at the child's increasing ability to deal with stressful situations when they top up.
Okay.
Their improved capacity to cope with difficult feelings or events, and whether they seem to gain confidence in their own ability to handle future stressors. It's really about building that inner strength, that resilience.
That's a great way to frame it. Okay, moving from general stress to more specific conditions, ADHD comes up a lot in childhood. What are the hallmark symptoms according to these sources?
The core symptoms listed are inattention, hyperactivity, and impulsivity. You can kind of think of them as the big three for ADHD.
Right. And if a child is diagnosed, what do the sources outline as the priority nursing interventions? What's the approach?
It's usually multifaceted. Individual and family therapy are important. Implementing behavior management strategies, providing emotional support that's huge for the child and the family, working to promote the child's self-esteem, and then pharmacology or medication when it's appropriate.
Methylphenidate is specifically mentioned in the sources as a medication sometimes used. How does it help, and what are a couple of common side effects to be aware of?
Right, methylphenidate. It's a stimulant, and in ADHD, it helps by increasing attention span and concentration. It works on certain brain chemicals.
Okay.
The sources list 2 common side effects parents should know about: weight loss and insomnia, or difficulty sleeping.
Good to know. What other crucial education should families of kids with ADHD receive?
A key piece highlighted is that children with ADHD are often at a higher risk for physical injury.
Oh, right, because of the impulsivity or inattention.
Exactly. So practical safety tips are vital. The sources suggest advising parents to give simple tasks, maybe allow more time for things, help decrease distractions in the environment,
Makes sense.
and establish and really stick to a structured daily routine. These things can make a huge difference in managing daily life and reducing risks.
Now, the sources bring up a concept that's, well, it's quite dated and pretty controversial, but it's in the material, so we should address it. McDonald's triad, what is this?
Yeah, McDonald's triad lists 3 specific childhood behaviors: bedwetting that continues way past the typical age, cruelty to animals, and pyromania, which is setting fires.
And what was the theory's belief about these 3 things together?
The source states the theory believed these specific behaviors could be potential predictors for later violent behavior, specifically mentioning serial killers.
Right.
It's really important for you, the listener, to know this is a historical theory. It's highly debated, not really accepted or used in modern psychology because the predictive evidence just isn't strong. But it was in the sources we received.
Okay, acknowledged.
Yeah.
Just covering what's in the material. Shifting gears, attachment disorder is mentioned. How does this develop in children?
It really stems from those crucial early interactions, or sometimes the lack thereof, between an infant and their main caregiver. It can develop if the infant can't respond appropriately to the caregiver, or the caregiver can't respond appropriately to the infant, or often it's a mix of both. It disrupts that vital bonding process.
And what might that look like? What are the assessment findings or signs?
The sources list things like feeding disorders, failure to thrive, FTT, where the child isn't growing or gaining weight, properly generalized anxiety disorder, and specifically reactive attachment disorder, where forming healthy attachments is really difficult for the child.
Depression in children is also something that can look different than in adults. The sources use the acronym SAD faces to detail signs across age groups. Can you break down SAD faces for us?
Absolutely. It's a helpful mnemonic. S is for sleep disturbances, sleeping too much or too little.
Okay.
A is for anhedonia, that's losing interest or pleasure in things they used to enjoy.
Right, nothing seems fun anymore.
Exactly. D is for despair, feelings of hopelessness, deep sadness. F is for fatigue, low energy, feeling tired all the time. A is for appetite changes, eating way more or way less. C is for concentration difficulties, trouble focusing, making decisions. E is for emotional sensitivity, being easily upset, crying a lot more. And S is for suicidal ideation, thinking about death or suicide.
That last one, suicidal ideation, is incredibly serious. The sources are really clear on this. What's the absolute first nursing priority if there's concern about depression, especially relating to that S?
The number 1 priority, the immediate action, is to assess for suicidal ideation SI and ensure the child is safe. Physical safety comes first. Period.
And the material points out specific phrases that should really raise a red flag and need immediate follow-up.
Yes, things like, I don't want to be here anymore, or nothing brings me joy anymore. Those are listed as urgent indicators that SI needs assessment right away.
Okay.
Other important actions include helping with daily activities if needed, making sure they get prescribed meds, fostering family support, checking in frequently about bullying online too, and trying to foster hope.
Expanding on the suicide assessment itself, what key areas do the sources suggest exploring when assessing a child's risk? What's behind the thoughts?
The assessment should really delve into the child's desire, their desire to die, maybe a desire to hurt others, a desire to escape something painful like bullying or abuse, or even a desire to punish themselves because of guilt. Understanding the why is crucial.
Okay, let's look at 2 conditions sometimes confused: oppositional defiant disorder, ODD, and conduct disorder, CD. How does the source material define them?
So ODD is described as this persistent pattern of being disobedient, argumentative, having angry outbursts, low frustration tolerance, and often blaming others for their mistakes.
Okay.
Conduct disorder, or CD, is more serious. It involves repetitive, serious violations of social norms and the rights of others. Think aggression towards people or animals, destroying property, cruelty.
And what's the key difference between ODD and CD that the sources really highlight?
The critical distinction noted is remorse. Children with ODD typically do feel remorse or guilt after they've acted out. Children with conduct disorder generally lack empathy and remorse. They don't feel bad about hurting others or breaking rules.
That's a big difference. Okay, moving on. Autism spectrum disorder, ASD. It's defined by stereotype behaviors or activities. The sources list quite a few characteristics someone might notice.
Yes, the list is pretty specific. It includes things like not talking by age 1, not responding to their name, seeming like they can't hear even though their hearing's fine, having really violent tantrums, showing odd or repetitive movements. Also, not smiling much, poor eye contact, preferring to be alone, lining objects up rigidly, having strong obsessions or compulsions, maybe an unusual attachment to specific objects. These aren't just quirks. They're part of the core differences in how someone with ASD experiences the world.
Right. What are the suggested nursing interventions for a child with ASD based on these sources?
Key things include providing resources for early interventions, getting support early is huge, establishing structure and firm rules, using positive reinforcement for desired behaviors.
Makes sense.
Working to decrease stimuli in their environment that might be overwhelming for them, and providing social skill training to help navigate social interactions.
And what should a teaching plan for families caring for a child with ASD cover?
The teaching plan should focus on continuing that social skill training at home and out in the world. Strategies for enhancing communication, which can vary a lot depending on the child.
Right.
Methods for boosting cognitive skills and supporting their academic and vocational readiness as they get older. The sources also delve into eating disorders, describing 3 main types.
Anorexia nervosa first. It's described as self-starvation, driven by this intense preoccupation with body image and thinness, leading to being less than 85% of ideal body weight.
Yeah, and the complications listed are serious, stemming directly from malnutrition, muscle wasting, dehydration, electrolyte imbalances, which can be really dangerous for the heart, cardiac dysrhythmias, irregular heartbeats, and an increased risk of infection because the body's just weakened.
Then there's bulimia.
Bulimia involves recurrent episodes of binge eating, followed by compensatory behaviors purging, like vomiting, using laxatives, fasting, or excessive exercise.
Right.
The source notes people with bulimia often appear at a normal weight, and it's generally not seen as immediately life-threatening like severe anorexia, but it definitely has its own complications.
Such as?
Damage to tooth enamel from stomach acid is a big one, and Russell's sign calluses or marks on the knuckles from inducing vomiting repeatedly.
And the third one is compulsive overeating or binge eating disorder.
Right. This is described more like an addiction to food. Uncontrolled binge episodes, eating large amounts quickly, even when full. But unlike bulimia, there's no purging afterward.
And the complication listed.
Feeling intense guilt, shame, or depression after the binge. Moving to the really challenging topic of child abuse, the sources specifically mention Munchausen's by proxy and physical abuse.
Munchausen's by proxy, defined as a form of abuse where a caregiver, often the mother, according to the source, intentionally makes the child seem ill or actually causes illness.
Yeah, it's a really complex situation. What might make a nurse or doctor suspect this is happening? The sources list provider shopping.
Taking the child to tons of different doctors.
Exactly, seeking diagnoses everywhere, and reporting made-up or exaggerated symptoms that just don't line up.
How is it investigated?
The sources suggest the child might be admitted to the hospital for observation and testing away from the suspected caregiver, and sometimes camera monitoring of the caregiver's actions in the hospital room is used.
That's incredibly difficult and disturbing. For physical abuse, what are some common clinical findings listed? Signs to look for?
Findings can include bruises or cuts, especially in areas usually covered by clothes that's suspicious because accidental bumps are usually on knees, elbows,
Exposed areas?
Marks from objects like belts, ropes, cords. Adult bite marks are a definite red flag. Bald spots from hair pulling. And behavioral signs, too. The child might be overly aggressive or fearful around adults, or weirdly indiscriminate, like overly friendly with strangers.
Oh. It's clear that pediatric mental health covers such a wide range, from internal struggles to these awful external dangers. Requires so much careful observation.
Absolutely. These sources give vital details for recognizing those signs. Okay, let's transition now to another area with its own unique set of physical challenges in kids, genetic and reproductive health. The sources start with vulvovaginitis.
Okay, inflammation of the vulva and vaginal area. What do the sources say about how this shows up in kids? What are the symptoms?
Symptoms listed are vaginal itching, pruritus, soreness, redness, or erythema, maybe a thin vaginal discharge, and painful urination. Basically, the tissue is irritated and inflamed.
And what are the nursing interventions and education points? What helps?
Education is mostly focused on simple hygiene. Teaching front-to-back wiping after using the toilet, maybe using moist wipes, emphasizing cotton underwear for better air circulation,
Good tip.
avoiding tight clothing or tight sleeper PJs, and recommending daily warm baths, just 10-15 minutes, clear water, or maybe a tiny bit of gentle soap, then patting the area dry, not rubbing. These steps help reduce irritation and prevent bacteria from growing.
Next up, physiological phimosis. What is that and when do we see it?
Physiological phimosis is when the foreskin can't be retracted back behind the head of the penis, the glans, and it's noted as being present in almost all newborn males.
And the source specifically asks, is this normal?
Yes. It's considered a normal finding in newborns. It usually resolves naturally as the child grows.
So how should families be educated about this?
Education involves counseling parents that it typically resolves on its own by adulthood for most boys. No specific treatment needed. Gentle stretching exercises might be shown. Sometimes a doctor might prescribe a topical steroid cream to help, but often it's just watchful waiting.
Okay. Moving to other structural differences, hypospadias and epispadias are mentioned.
Right. Hypospadias is when the urethral opening is on the underside, the bottom of the penis, instead of the tip.
Epispadias.
Is the opposite. The opening is on the top side of the penis.
Are either of these emergencies?
No, the sources state these aren't typically emergencies. Surgical repair is usually planned for later, generally between 6 and 12 months of age.
So what's the initial recommendation when these are found?
Delay circumcision. That's really important because the surgeon often needs that foreskin tissue for the repair and refer them to a pediatric urologist for evaluation and surgical planning.
Cryptorchidism is the next condition discussed. What's that?
That means undescended testes, one or both testes, haven't moved down into the scrotum where they belong.
Is this a surgical emergency?
No, like hypospadias, it's not an emergency. Surgical correction, called an orchiopexy, is usually done between 6 and 18 months.
And when should families definitely seek treatment if they notice this?
The source notes, if the testes haven't descended on their own by age 2, it's important to see a surgeon to evaluate for surgery. Waiting too long can impact testicular health later.
Hydroceles sounds related to the testes too.
It is. A hydrocele is a collection of fluid in the sac that surrounds the testicle.
Is it painful?
Generally, no. Hydroceles are usually painless.
And how is it treated?
Most hydroceles in infants resolve on their own, spontaneously, by about 1 year of age.
Okay, how about varicocele?
A varicocele is a collection of enlarged veins within the scrotum, kind of like varicose veins you might see in legs, but in the scrotum.
Is that painful?
Usually painless, though some guys might feel a dull ache. On exam, it's often described as feeling like a bag of worms.
And treatment?
Often, it's just watch and wait, unless it's causing significant symptoms, pain, or maybe affecting testicular growth. Then surgery might be considered.
Now, testicular torsion sounds different, more serious.
Yes, testicular torsion is a true emergency. It happens when the spermatic cord, which supplies blood to the testicle, twists on itself.
Oh, wow.
This cuts off the blood supply, and it's extremely painful.
What are the signs to look for?
The key is abrupt, severe, constant pain in the scrotum. It can radiate up to the lower abdomen or groin, often comes on very suddenly, very intense.
Okay.
Nausea and vomiting are common too, and the scrotum on that side will look swollen, edematous.
So definitely a surgical emergency.
Yes, absolutely. Time is critical to save the testicle. Treatment involves managing the severe pain and immediately prepping for surgery to untwist the cord and restore blood flow. Age-appropriate prep for tests or surgery is also important.
Inguinal hernia is next on the list. What's that?
An inguinal hernia happens when abdominal contents, like a loop of intestine, pushes through a weak spot in the muscle wall in the groin area through the inguinal rings.
How is it identified?
Usually a visible lump or bulge in the groin, often on the right side. Some might feel a burning or gurgling feeling there.
How is it treated?
Parents can often be taught how to gently reduce the hernia. carefully push the bulge back in, it's important to check if it is reducible.
Okay.
Surgery is typically recommended to fix the weakness, and it becomes urgent if the hernia gets incarcerated.
What does incarcerated mean, and what's the risk then?
Incarcerated means the bulging stuff is trapped, it can't be pushed back in. If that happens, there's a significant risk for strangulation.
And strangulation is?
A surgical emergency. It means the blood supply to that trapped tissue, usually intestine, is cut off. That tissue can die if it's not fixed quickly. The sources also touch on sexually transmitted infections, STIs, in the pediatric group, which can happen congenitally or later in adolescence.
What risk factors do the sources list for getting STIs?
They list both behavioral and biological risks. Behavioral things like multiple or new partners, partners who have multiple partners, inconsistent condom use, alcohol or drug use impairing judgment. Biological factors like cervical ectopi or immaturity, which can make an adolescent's cervix more vulnerable to infection.
Why is erythromycin ointment used in newborns' eyes right after birth?
That's prophylactic. It's a preventative measure to stop serious eye infections caused by bacteria they might pick up in the birth canal.
Like gonorrhea or chlamydia?
Exactly, and other common bacteria too. It's standard procedure because those eye infections in newborns can be really severe.
Congenital syphilis, passed from mother to baby during pregnancy, is mentioned. What kind of problems can that cause in infants?
Sadly, it can cause stillbirth or premature birth. For infants born alive, the signs can be really wide-ranging. They might have chronic runny nose called snuffles, enlarged liver and spleen, a rash, often on palms and soles, starting pink red then maybe turning coppery, bone abnormalities causing pain, fractures, limited movement, sometimes called pseudoparalysis of Parrot.
Wow.
And CNS involvement is possible too. Seizures, hydrocephalus, fluid on the brain, developmental delays, or losing milestones they'd already hit. Okay, moving into conditions that are specifically genetic. Trisomy 21, commonly known as Down syndrome, is detailed in the sources.
What is trisomy 21 fundamentally? What's the genetic basis?
It's a chromosomal disorder. Instead of the usual 2 copies of chromosome 21, people with Down syndrome have 3 copies. That extra genetic material causes the characteristics and health issues.
The sources list several distinct physical signs.
Yes, they include specific facial features, small, kind of flattened head, flat mid-face, eyes that slant upwards with skin folds at the inner corner epicanthal folds, small mouth, maybe protruding tongue, low-set ears.
Okay. Also, broad chest, common heart murmurs from defects, short hands, sometimes the single crease across the palm.
What are the priority nursing interventions for a family getting this diagnosis?
The focus is strongly on supporting the family, helping them adapt, providing emotional support, offering resources, support groups, early intervention programs, community services specifically for Down syndrome. Connecting them is key.
And what kind of education is important for these families?
Specific feeding techniques are often needed due to muscle tone and mouth structure differences, positioning upright, cheek support, pacing feeds,
Right.
teaching parents to watch for breathing or color changes during feeding, general info about the disorder, potential health issues like heart defects or thyroid problems, and clear guidance on when to seek medical help are all vital.
Turner syndrome is another genetic condition mentioned. What's that one?
Turner syndrome affects females. It results from losing all or part of the second X chromosome. So instead of XX, they usually have just one functional X chromosome, often written as XO.
And this only affects females. Yes, because it involves the X chromosome. It's a female-only disorder.
What are the signs and symptoms listed in the sources for Turner syndrome?
Higher rate of prematurity. Physical features can include a thick or short webbed neck, short stature, which becomes more obvious over time,
Okay.
a broad chest with wide space nipples, and importantly, non-functional ovaries, leading to infertility and no spontaneous puberty. Other potential issues are kidney defects, some learning disabilities, especially math spatial, swelling, lymphedema in hands, feet, feeding issues in infancy, and higher risk for thyroid problems.
What are the suggested nursing interventions?
Anticipating feeding difficulties in infancy, being patient. Growth monitoring is critical, using special Turner syndrome growth curves. Watching height velocity, especially if they get growth hormone therapy. Regular checks for associated medical conditions, hypothyroidism, diabetes, heart issues. That means a baseline EKG, regular cardiac monitoring, and checking blood pressure at every visit because hypertension risk is higher.
And family education for Turner syndrome.
Referral to endocrinology early, often for growth hormone therapy to boost adult height. Estrogen is needed to start puberty, but families need to understand infertility is still expected due to the non-functional ovaries.
Right.
Guidance on obesity risk later. and explaining that while birth size might be typical, their height growth slows down significantly compared to peers.
Fetal alcohol spectrum disorder, FASD, is unique because the source says it's not genetic.
That's a critical point. FASD is a range of effects from maternal alcohol use during pregnancy, caused by alcohol exposure, not a gene issue.
And who does FASD affect?
Both male and female children can be affected.
The sources list specific facial features often associated with FASD.
Yes, the classic features include a flat midface, thin upper lip, small chin, short upturned nose, short eye openings, palpebral fissures, prominent inner eye folds, epicanthal folds.
Yeah.
Beyond the face, kids with FASD often have growth difficulties, abnormal brain development leading to cognitive and behavioral issues, speech delays, and sensory overreactivity, very sensitive to textures, sounds, lights.
What nursing interventions are listed for a child with FASD?
Addressing the specific challenges. For infants, maybe issues coordinating sucking, swallowing, breathing could lead to aspiration or need for feeding tubes.
Right.
Addressing sensory issues, managing textures, behavior management, and environmental changes for attention problems and impulsivity, and recognizing related conditions, comorbidities.
And key education for families.
The absolute most crucial message: any alcohol during pregnancy is safe, period. Avoid it entirely.
Definitely.
Families also need education on common issues like impulsivity, significant attention problems often meets criteria for ADHD, and executive dysfunction problems with planning, organizing, completing tasks. Understanding helps provide the right support.
Finally, in this section, cystic fibrosis, CF.
CF is inherited, an autosomal recessive disorder. Need the mutated gene from both parents. It affects exocrine glands, those making mucus, sweat, digestive enzymes.
Cool.
In CF, you get abnormally thick, sticky mucus and decreased pancreatic enzymes for digestion.
What are the clinical manifestations, especially respiratory ones?
Respiratory symptoms are big due to thick mucus clogging airways. Wheezing, raunchy, rattling sounds, persistent cough, shortness of breath, dyspnea, clubbing of fingertips over time, a barrel chest if chronic, and cyanosis, bluish color from poor oxygen.
How is CF tested for?
The gold standard is the sweat chloride test, measures salt in sweat. It's abnormally high in CF. Newborn screening can pick it up early. Chest x-rays show characteristic changes. And genetic testing identifies the specific CF gene mutations.
What are the nursing interventions for managing CF? It sounds complex.
It is. Maintaining airway clearance is essential chest physiotherapy, CPT, vibrating vests to loosen mucus, low-flow humidified oxygen if needed. Nutrition support is critical due to poor absorption, maybe tube feeds or IV feeds. Antibiotics often for lung infections, anti-inflammatory sometimes, individualized diets with pancreatic enzymes, extra vitamins, especially fat-soluble, and calories with every meal and snack. Routine monitoring of lung function and nutrition, promoting a normal lifestyle as much as possible, and post-op care if a lung transplant is eventually needed.
Are there specific contraindications or precautions mentioned for CF?
Yes, avoid antihistamines. They can dry mucus, making it even thicker and harder to clear.
Good point.
And a big precaution. Frequent hospitalizations are common, and it's vital to keep CF patients separate from each other in the hospital. Certain bacteria colonizing their lungs can easily spread between them and cause worse infections. Wow, that covers a lot of critical info on genetics and reproductive health. Let's shift now to another area where those unique differences in a child's anatomy are super important: pediatric respiratory conditions.
This really hits home. That point you made earlier, a child is not a miniature adult. The source highlights key differences in the pediatric airway compared to ours.
Absolutely. A child's upper airway is significantly shorter and narrower, means it can get blocked more easily.
Right.
Their larynx, the voice box, is more flexible and higher up, so it's easily stimulated to spasm, potentially closing the airway. They have a higher metabolic rate, higher oxygen demand, need oxygen delivered efficiently.
Okay.
And their tonsils and lymphoid tissues are proportionally much larger, which can contribute to obstruction when swollen.
The source briefly mentions safe sleep practices in relation to this, though the outline didn't detail the connection fully.
Correct. But understanding how vulnerable that infant airway is, how easily it can be compromised, definitely reinforces why practices like putting babies on their backs on a firm, flat surface are so important for keeping the airway open.
Makes sense. Moving to common infections, otitis media, ear infections, otitis media with effusion, OME, and otitis externa, OE, swimmer's ear.
Yeah, treatment often involves being conservative with antibiotics, especially for simple OM, as many are viral or resolve on their own. For recurrent infections, putting in pressure equalizing, PE tubes might be needed. Supportive care is key. Pain relievers, fever reducers, hydration, sometimes topical pain drops for the ear.
What's a potential long-term risk with chronic ear infections?
Conductive hearing loss is a risk. Fluid buildup or changes in the middle ear can mess with sound conduction. Hearing tests, audiometry, might show that loss.
Tonsillitis, inflammation of the tonsils, and tonsillectomy, removing them, are common kid issues. What exactly is tonsillitis?
It's inflammation of the palatine tonsils, those lumps of lymphoid tissue you see in the back of the throat. Can be bacterial or viral.
What would you see? What are the assessment findings?
Child usually complains of a sore throat. The tonsils look enlarged, red, maybe have white or yellow spots or coating. Exudate. Difficulty swallowing is common. If the tonsils and adenoids, the lymphoid tissue behind the nose, are really big, the child might mouth breathe, have bad breath, halitosis, snore, and potentially even obstructive sleep apnea because the airway gets blocked during sleep.
When is a tonsillectomy typically recommended?
Usually for kids with really frequent recurrent tonsillitis or chronic tonsillitis, especially if it's causing problems like airway obstruction or trouble eating.
After a tonsillectomy and adenoidectomy, TNA, what are some normal things to expect and what are the red flags?
Normal findings post-op include seeing some dark brown, old blood in the throat, that's expected, a hoarse voice, maybe some nausea.
Okay.
Abnormal findings to watch for, frank, bright red blood. Or continuous swallowing that can be a subtle sign they're swallowing blood dripping down their throat. Active bleeding.
Right.
And education includes avoiding red, spicy, or acidic foods that could irritate the area. Croup syndromes are also discussed, known for that very distinct cough.
Yeah, what is croup?
Croup is an inflammatory process hitting the voice box, larynx, windpipe, trachea, and the bigger airways, bronchioles, usually viral, causes swelling in those airways.
Leading to that specific cluster of symptoms.
Exactly.
Do we usually treat croup with antibiotics?
No, the sources say because it's usually viral, antibiotics don't help. Treatment focuses on reducing inflammation, mainly with corticosteroids.
What are those trademark signs of croup?
The most recognizable is that seal-like barky cough, often worse at night. They'll also have inspiratory stridor, that high-pitched sound when breathing in due to the narrow airway. Mild respiratory distress, maybe a fever, maybe not.
How is it treated at home versus if it's more severe?
Home treatment often involves oral corticosteroids like dexamethasone, maybe a cool mist humidifier. For moderate to severe symptoms, especially stridor when resting, inhaled epinephrine might be given in a clinic or hospital to quickly shrink the swelling. Bronchiolitis, often caused by RSV, respiratory syncytial virus, is another frequent pediatric respiratory illness.
What exactly is bronchiolitis?
It's acute inflammation of the bronchioles, those really tiny airways deep in the lungs. The sources mention superinfection, possibly meaning kids with bronchiolitis are at risk for secondary bacterial infections on top of the virus. What does bronchiolitis look like clinically? Symptoms come from the narrowed airways and mucus. You'll hear wheezing and crackles in the lungs. Apnea, pauses in breathing can happen, especially in preemies.
Carrie.
Other signs: nasal congestion, low-grade fever, dry, non-productive cough, fast breathing, tachypnea. It can progress to significant respiratory distress, exhaustion, even respiratory failure in severe cases.
How is it treated at home?
Home care is supportive. Good hand hygiene is crucial to stop spread, making sure they get enough fluids, using saline drops to loosen nasal mucus, antipyretics for fever.
And in the hospital, care gets more intensive.
Yes. Hospital care involves continuous heart and respiratory monitoring, pulse oximetry, NG or IV fluids if they can't drink enough. High-flow positive pressure humidified oxygen can help breathing. Nebulized hypertonic saline, sometimes used to help clear mucus. Chest physiotherapy, CPT. Postural drainage, suctioning, especially the nose, are important. And palivizumab is mentioned. That's the monthly shot during RSV season to prevent severe RSV in high-risk infants, like preemies.
Respiratory distress syndrome, RDS, is a major issue, especially for newborns.
Right. RDS is mainly seen in premature infants. It's inflammation in the tiny air sacs, alveoli, related to underdeveloped lungs and not enough surfactant.
Surfactant. That's the stuff that keeps the air sacs open.
Exactly. It's like a soapy lining. Without enough, the sacs collapse, making breathing incredibly hard.
What do the signs of RDS look like?
Clear signs of respiratory distress. Tachypnea, breathing really fast, over 60 breaths a minute. Retractions are very common: skin pulling in between ribs, below ribs, above the collarbone, below the breastbone, at the neck notch. Really working hard to breathe. Nasal flaring. cyanosis, bluish skin, grunting sounds with breathing trying to keep air sacs open, fine crackles, rails in the lungs, and diminished breath sounds because air isn't moving well.
And what does a chest X-ray typically show?
The classic look is a ground glass pattern throughout the lungs, hazy, indicating tiny collapsed sacs. You might see the airways standing out against that haziness. Visible bronchial tree. Maybe some dark areas of trapped air.
What are the priority nursing interventions for an infant with RDS?
Vigorous respiratory monitoring and support are key. Close observation, pulmonary hygiene, early use of positive airway pressure like NCPAP or mechanical ventilation to keep air sacs open.
Right.
Giving artificial surfactant directly into the lungs is a primary treatment. Antenatal steroids given to mom before a premature birth can help mature baby's lungs. Maintaining stable body temp, nutrition, fluids, electrolytes, and preventing infection are also critical.
Asthma is a very common chronic condition in kids.
Yes, asthma. Chronic inflammatory disorder of the airways. It's obstructive because the inflammation leads to hyperresponsiveness. Airways react strongly to triggers, causing swelling, narrowing, and more mucus. All obstructs airflow.
What are the typical clinical signs of asthma in children?
Cough is common, often non-productive or frothy, frequently worse at night or with exercise. Shortness of breath, chest tightness, wheezing, that whistling sound, usually on exhale. Prolonged expiration takes longer to breathe out.
Right.
If it's chronic, maybe a barrel chest over time. And an ominous sign, really bad obstruction, is hearing coarse or absent breath sounds. If you can't hear air moving, it's blocked.
What are priority nursing interventions during an asthma flare-up?
Immediate priorities are oxygen and bronchodilators like albuterol to quickly open the airways. Beyond that, the focus is prevention. Ongoing respiratory assessment, identifying and managing triggers like dust or pollen, and lots of education for the child and family.
A peak flow meter is a key tool for home management. What does it do?
It's a handheld device measuring how fast someone can blow air out forcefully. Shows their breathing capacity, not for diagnosis, but for monitoring lung function, seeing if daily therapy is working.
Right.
An action plan is usually based on readings, using color zones green, yellow, red to guide daily management and know when to get help.
What's essential discharge education for families dealing with asthma?
Teaching correct inhaler technique, especially with a spacer or aero chamber, is vital. Emphasizing taking controller meds daily, even when feeling fine, to prevent flare-ups. Identifying and avoiding specific triggers, general prevention strategies.
And specifically, how should a metered dose inhaler, MDI, be used according to the steps?
Shake it well. Tilt head back slightly. Breathe in slowly and deeply as you press the canister. Hold breath for 10+ seconds if possible. Exhale slowly. Wait about a minute between puffs if you need more than one.
Okay.
Rinsing the mouth afterward is good, especially with steroid inhalers, to prevent thrush. Spacers help get more medicine to the lungs instead of the throat and make coordination easier, especially for kids.
Apnea in infants. That sounds terrifying for parents. How is it defined in the sources?
Apnea is stopping breathing. Clinically, usually defined as a pause longer than 20 seconds. But it's also apnea if any shorter pause comes with concerning signs like cyanosis, blue skin, bradycardia, slow heart rate, pallor, paleness, or hypotonia, floppy muscle tone.
How can caregivers help prevent apnea?
Simple things like positioning the infant correctly back to sleep on a firm surface helps keep the airway open. Sometimes gentle stimulation, like rubbing their back or feet, can prompt them to breathe.
What's an apnea monitor used for then?
It tracks breathing and heart rate, alarms if breathing stops or heart rate drops. Doesn't prevent apnea, but it's an early warning, sometimes indicating underlying issues like sepsis or respiratory distress.
This leads to ALTE, apparent life-threatening event, or the newer term BRUE, brief, resolved, unexplained event. What's that?
Describes a sudden episode in infants under 4 months, born 37 weeks. A sudden change in breathing, color, muscle tone, or responsiveness that's scary for the caregiver, but then resolves on its own. Called unexplained because a clear cause isn't always found afterward.
What are some risk factors for an ALTE-BRU?
Sources list things to investigate. Reflux, GERD, respiratory infections, seizures, feeding aspiration, heart defects, and sadly, sometimes child abuse.
What are the nursing interventions if an infant has had one of these events?
Close monitoring is key apnea monitoring, continuous heart and breathing monitoring with pulse oximetry, ensuring optimal feeding position, reinforcing safe sleep. Because these are so scary for parents, providing emotional support is really important.
Finally, epiglottitis is listed as potentially life-threatening. What is it?
Epiglottitis is serious, rapid inflammation of the epiglottis that flap at the base of the tongue covering the windpipe. Swelling there can quickly block the airway. Life-threatening emergency.
What are the critical signs that should make someone suspect epiglottitis?
Onset is usually sudden and severe. High fever, severe sore throat. Kid looks restless, agitated, anxious, fast heart rate, fast breathing.
Yeah.
Hallmark sign is the tripod position, leaning forward, arms braced, neck extended, trying to keep the airway open. And the classic 4 Ds and S, drooling, can't swallow saliva. Dysphagia, trouble pain swallowing. Dysphonia, muffled voice hoarseness. Distressed breathing in. And stridor, high-pitched sound breathing in.
Given how fast this can turn bad, what should the nurse do?
Monitor respiratory status extremely closely. Things change fast. Crucially, try not to make the child cry. It can worsen swelling, trigger spasm. Give prescribed meds, often antibiotics and maybe steroids, 5E fluids for hydration, emotional support for the terrified family, and be ready for intubation, likely in the OR where it's safest to manage the airway.
And just as important, what should the nurse not do?
Do not try to look in the mouth or throat with a tongue depressor unless you are fully prepared for immediate emergency intubation with all the equipment and personnel right there.
Why not?
Stimulating that area can trigger a sudden complete airway spasm, full occlusion. It's incredibly high risk. Avoid it unless you're ready for the worst-case scenario airway procedure. Wow, we've really covered a huge amount of ground here, haven't we? Took a deep dive across a massive range.
Absolutely. From, recognizing those subtle behavioral cues of stress and specific symptoms of things like depression or ADHD, to navigating complex genetic syndromes and understanding those critical differences in a child's tiny, vulnerable airway like with RDS or epiglottitis.
It's such a powerful reminder of how unique pediatric health truly is, and why specific knowledge is just so vital. By walking through these details from the sources, the signs, the risks, the interventions, why they matter, hopefully, you gain a much deeper appreciation for the nuances of caring for children.
Yeah, and hopefully feel better equipped to recognize potential issues or just understand the care being provided.
Exactly.
You've just extracted some incredibly important information about pediatric health, helping you understand the unique vulnerabilities, but also, I think, the remarkable resilience of children navigating these challenges.
Yeah, definitely. And it does leave you thinking, doesn't it? How does understanding these distinct, sometimes really profound challenges faced so early in life reshape our view of resilience itself? Not just for the child going through it, but also for the parents and caregivers who are right there with them, supporting them every single step of the way. Something to consider after this deep dive.